Traditionally, physicians, nurses, and other healthcare providers have tended to think about helping patients in terms limited by the existing definitions of their roles, where the interaction between patient and provider is considered in relation to the specific areas of their individual expertise, rather than in terms of the actual needs of the patient. Now we are beginning to ask what the problems are in the patient's terms and what skills are needed to deal with these problems. We are drawing away from the traditional approach in which the doctor selects essentially those aspects of the patient's needs he can deal with given his training and leaves the remainder for others to contend with or ignore. At Beth Israel Hospital in Boston, we have been trying to ask this new question. With the reorganization several years ago of our traditional teaching hospital clinics into Beth Israel Ambulatory Care Center, we eliminated the general medical, obstetrics, gynecology, and pediatric clinics and replaced them with a system of primary care delivery which was designed to serve patients coming to the hospital for continuing primary care and an additional walk-in unit for patients seeking episodic care or entry into the primary care system. At the same time, the specialty clinics were reorganized into strictly referral and consultative units, but it is BIAC, the primary care group practice, that I still shall discuss. 10 full-time salaried physicians replaced the many voluntary physicians who previously provided episodic care. The switchover from old-time clinics to BIAC took place overnight. There was neither time nor money to train providers of care to work in teams. Nevertheless, from the first day, the policy was teamwork, and the emphasis was on patient-centered issues. That by BIAC worked is a tribute to Dr. Thomas Del Banco, medical director of BIAC, and his colleagues. We wanted to learn whether the delivery of primary care by teams of varied personnel might prove useful and effective in the setting of a university hospital. Thus far, our experience has been positive. The basic team consists of a physician, nurse, social worker, secretary, and aide. The staff doctor may be joined by an intern, resident, or medical student. The nurses are nurse practitioners, midwives, or nurse clinicians. Nursing students also may join the team. The social worker's training may range from that of a case aide up to an experienced social worker with a master's degree, generally with some background in both medical and psychiatric casework. Student social workers at various levels of training also join the teams. These three categories of individuals, doctor, nurse, and social worker, all use the medical records identically. Their observations are recorded chronologically and assigned equivalent import and validity. All three use the problem-oriented format. Secretaries also are members of the team because of their personal involvement with the patients in BIAC and in recognition of the fact that many, particularly elderly patients, use the social interactions of the waiting room as a meaningful component of their therapeutic relations. In refusing to stick to the traditional limits of the various specialties, we have seen the evolution of the role of doctor, nurse, social worker, and secretary. For example, at first, the nurse saw patients for follow-up after the diagnosis and treatment had been established by the physician, essentially. She was monitoring the physician's prescription. Subsequently, her role was expanded to work up new patients who were expected to be essentially healthy, such as young adults in for college checkups, for example. Now, as we go into the fourth year of BIAC, nurses see random new patients and, to the extent permitted by law, render close to independent diagnostic and therapeutic decisions. One advantage of the team in this situation is that the physician is next door and is available for immediate consultation if needed. This allows the nurse a broader range of operation within her expertise than that enjoyed by an isolated caregiver in an outreach clinic, where no second opinion is available immediately. The training of nurses and nurse practitioners to fit the team has been variable. Nurses have joined BIAC with a variety of backgrounds and, of course, have developed additional skills at Beth Israel Hospital. We cannot say whether one particular type of training is superior to, but we suspect that superior performance depends more on the individual than on a particular curriculum. Another example of the team approach has been the inclusion of mental health care in primary care at BIAC. The full-time psychiatric or psychiatrist in the group spends but half his time with individual patients. During the remaining half, he teaches and supervises other members of the team. Doctors, nurses, social workers, and secretaries are taught to recognize that much of the interaction between any team member and a patient will have more to do with the so-called mental health aspects of the patient.